Thank you all for being a part of this panel and for coming to join us for our March lunch series. I always have to remember what month it is and which event we're doing. But GSDI's lunch series is really an opportunity for us to highlight the work that's happening within the center. And this month we're highlighting the work that the PhD students at UNC, the work that they've been doing. So hopefully we will have more opportunities like this in the future for other students to also present the work that they're doing. But this month we're focusing on social and economic aspects of health through the life course and using some of the evidence from Zambia. Since there are a few of us, I'll just breeze through. For Zoom considerations, we're all accustomed to this. Webinars being recorded. Just keep your video out and microphone off during the presentations, and then we'll follow and conclude with a moderated Q&A. And I will just turn it over to Dr. M to introduce our panelists because you've really been working with them very closely.
Okay, thank you, Miranda. So let me, well, I guess I'll just make them introduce themselves since I think they can, but yeah, so let's, they're all PhD students at our school and different stages of their PhD training. So let me start with Alex.
Hi, my name is Alex Forte. I am a second year doc student here in the School of Social Work. My research interests in general are food insecurity and the intersection of mental health.
Alex. Mel?
Hi, I'm Melissa Velotis. I'm a third year doctoral student at the School of Social Work. And my research interests are on neighborhood impacts on social connection and youth mental health.
Graham.
Hi, my name is Graham Zhu, and I'm a first year PhD student of social work. And my area of interest is HIV prevention with an intersectionality of financial inclusion as well as asset building.
And Steph.
Hey, my name is Stephanie Baca Atlas. I'm a fifth year doctoral student. I study the intersection, that's my cat, she wants to say hello. I study the intersection of structural interpersonal violence, substance use, and health inequities. I'm very excited to be here. Thank you very much for the opportunity.
Thank you all. Oh, sorry, go ahead, Evan.
Excellent, thank you all so much. We will get started with this presentation from Alex and Mel, talking about their work on the direct and indirect associations.
Hi, good afternoon, everyone. So like I mentioned, I'm Melissa or Mel, so we have Alex here, and we had the privilege of working with Dr. Massa on this project that we are excited to share with you all. So let's dive in.
Nice. So I will jump into the background. So literature states that nutrition during adolescence affects cognitive and health performance, cognitive and academic performance and health outcomes, and that self-efficacy, or the belief in your ability to achieve a goal, is a predictor of cognitive and academic skills. In addition, being under or overweight has been identified as a predictor of adolescent girls' confidence and efficacy, again, their ability to believe that they can do something. And discriminatory gender norms, which put a low priority on girls' education, can impede their opportunities for cognitive and academic skill building. So the purpose of our study was to determine, oh, next slide. Thank you. Was to determine if self-efficacy and gender attitudes mediate the relationship of nutritional status. And for this purpose, nutritional status is being identified as underweight or normal weight, and its relationship with 4 indicators of cognitive and academic skills, which include math, literature, and arithmetic. And we also looked at the direct and indirect relationships and associations of these variables. Next slide.
So to explore our research questions, we used a longitudinal design with data collected from adolescent girls who participated in the Adolescent Girls Empowerment Program in Zambia. Our sample consisted of 5,236 Zambian girls aged 10 to 19 years old. But because of missing data, our final sample was 4,693 girls. We analyzed data collected at rounds 2 and 3 of the data set. Nutrition status, self-efficacy, and gender attitudes were examined at round 2, and cognitive and academic abilities were examined at round 3. Cognitive and academic abilities were the outcome variables and were measured using the score of a series of tests. So the Ravens progressive matrices test was used for cognitive scores, and academic abilities were examined using the scores from literacy, numeracy, and arithmetic questions in the data set. Nutritional status was measured using body mass index based on the height and weight of the participants, and then categorized as underweight, normal weight, and overweight or obese. Self-efficacy and gender attitudes were the mediators for our analysis. Self-efficacy was measured using the general self-efficacy scale, and gender attitudes were assessed using 5 questions based on measures in previous studies. Higher scores indicated higher self-efficacy and more negative gender attitudes. And lastly, the covariates that we used were social assets, material assets, and school attendance, as these were items that have been identified to influence key study variables, including self-efficacy and cognitive and academic abilities. Analyses were conducted using confirmatory factor analysis, or CFA, for gender attitudes and self-efficacy because they were the only latent variables, and structural equation modeling was used to test the entire model. We used weighted least square mean and variance adjusted estimators with missing values in this test. Next slide, please.
So these are the results of our CFA, or a confirmatory factor analysis, with our mediating variables of self-efficacy and gender attitudes. The results indicated a good fit of our final measurement model and the observed data, and all factor loadings were statistically significant. Our final measure included all 10 self-efficacy items from the study and 3 of the 5 gender attitude questions. Questions 1 and 5 were dropped as the gender attitude, those questions had an adequate model fit when they were included. Next slide. Thank you. So I know there's a lot going on here on this spider web, but I'm gonna walk us through it. So just to orient us to the slide, the circles represent the latent mediating variables of gender attitudes and self-efficacy that we saw in the previous slide. And the squares represent the observed variables. So the underweight and normal weight, and then the scores on the various academic and cognitive outcomes. So results indicated an adequate fit of our hypothesized structural equation model. And first we'll jump into our direct effects. So the direct effects for underweight, or girls that were underweight, had significantly lower cognitive scores, numeracy, and arithmetic skills than girls who were not underweight. Girls who were underweight also reported significantly lower self-efficacy than those who were not underweight. In contrast, normal weight didn't have any of these significant associations with cognitive skills, literacy, numeracy, or arithmetic skills. Nutritional status was not significantly associated with any of the gender attitudes. And so now looking at self-efficacy and gender attitudes, self-efficacy was significantly associated with cognitive and academic skills. So your belief in the ability to do something is associated with your outcomes on these measures. And negative gender attitudes were significantly associated with lower cognitive and academic skills. So if you believe in this population that women have less ability to do things, or you have negative attitudes towards women, you're experiencing lower cognitive and academic skills. And this is a population of all young girls, if you remember. So now looking at the indirect effects, which are mediating pathways. So there was a significant indirect effect of girls who were underweight reporting lower cognitive skills through self-efficacy. So if a young girl believes that she can't do as much as she doesn't really believe in her belief, that impacts her cognitive skills outcomes. In addition, being underweight also had a significant indirect effect through self-efficacy on literacy skills. So again, for underweight women, if I don't believe in myself as much, my literacy skills will also be lower. And this was the same for arithmetic and numeracy as well. So the belief in that ability to do something really impacts your outcomes on these scores. Next slide. So in conclusion, we can see that being underweight was a consistent predictor of low self-efficacy and cognitive and academic skills, and that being underweight influences these vulnerable adolescent girls' cognitive and academic abilities. And there's an importance, we really should focus on self-efficacy and the belief that you can do or achieve something successfully, which we can see impacts the ability to actually do things. And it's associated with poor nutritional status, or in this sample, underweight girls. And also, adolescent girls who are underweight may have other external factors. So feeling physical or bodily signs of undernutrition may be embarrassing, which can result in lower self-confidence and their belief in ability to do well in school. And this also, being underweight, can lead to frequent school absences, and you're more susceptible to illness. So these are some things that we like to think about. I'll let Mel finish us out.
Yeah, so in conclusion, the effective interventions might combine nutritional support, efficacy building through peer mentorship, socio-emotional skills training, and community-wide gender sensitization. Standalone nutrition or school meal programs, although they are necessary, may not be sufficient to maintain nutritional gains and positively affect self-efficacy, cognition, and academic skills. So there's much work to be done. So thank you for listening.
Yes, thank you.
Thank you both so much. Very interesting. I'm excited to learn more later in our moderated Q&A. I will now turn it over to Graham to talk about the work that you've been doing.
Thank you, Miranda. Thanks, everyone. So my research topic was basically the association of social support, HIV stigma, and HIV disclosure among young people living with HIV in Zambia. Next slide, please. Yeah, so just to give a short background, so there are 37 million people living with HIV, and more than half of these individuals, they live in the sub-Saharan Africa. And unfortunately, 1 in 10 of these individuals, they fail to disclose their HIV status. And moreover, we could say that the prevalence rate of HIV in the region accounts for, the HIV disclosure in the region accounts for 7 to 72%. And 3 in 4 new infections accounts for young people in this region. So speaking of HIV disclosure, studies have shown that HIV disclosure is an important factor, or it has positive effects on prevention, treatment, and prevention and treatment behaviors of individuals with HIV. However, at the same time, we could say that HIV disclosure has got negative effects. These negative effects may include social negative effects, may include stigma, discrimination, as well as isolation of these individuals suffering from HIV. Previous studies have shown that social support is an important predictor of HIV disclosure in adults. However, there are few studies in this realm, so to speak, that examines the role of social support in HIV disclosure among young people living with HIV. So we would say that there is a dearth of research on the association of social support with disclosure efficacy and perceived negative outcomes of disclosure. Next slide, please. So the objective of this study was basically to examine the association of different forms of social support and disclosure efficacy and perceived negative outcomes of disclosure in young people living with HIV in Zambia. Our next slide, please. So speaking of the methods, this study was a cross-sectional study, and we obtained a sample of 120 young people living with HIV in Eastern Province of Zambia. And we examined two outcomes in this study, that is disclosure efficacy and perceived negative outcomes of disclosure. And these two outcomes were measured using what we call the Adolescent HIV Disclosure Cognition and Affect Scale. Then the social support was measured using the Parental Social Support for Adolescents, excuse me, social support for adolescents, and the CATS Social Adjustment Scale. So our data was analyzed using the OLS regression, and our missing data was basically imputed using the multiple imputations by the chain equations. Next slide, please. And we had interesting results. We had interesting results in the sense that we found that the parental social support and the emotional social support and social adjustment were negatively associated with perceived negative outcomes of disclosure. However, we found that positive attitudes about living at home were associated with higher disclosure efficacy in young people. We also found that internalized and enacted stigma were also associated or significantly associated with disclosure in this population. And when you look at these results, they are similar to previous results in studies that were conducted in the sub-Saharan Africa as well. And in conclusion, next slide, please. In conclusion, we may say that the overall results of this study were supported by the hypothesis we had on the relationship of social support with disclosure, self-efficacy, and perceived negative outcomes of disclosure in young people living with HIV. And we would say that social support, HIV stigma, in addition to these results, would say that HIV stigma still remains a significant predictor of disclosure among young people. And disclosure of HIV status can also be influenced by higher levels of social support and other positive social, psychosocial factors, such as attitudes toward living at home. And I may also add to this one, there's a study, actually it was conducted in 2004. I forgot the authors of the study, but it's quite outdated. It simply tells us that in the sub-Saharan Africa, there's higher levels of social support compared to other places or geographic places in the world, due to the fact that there is a there's a good social support system in these areas. And so despite the fact of that, we may say that disclosure can also be negatively associated with undesirable social outcomes, which includes stigma. And when we speak of stigma, we may talk about the different types of stigma, which could be internalized stigma, expected stigma, as well as experienced stigma. And we could also talk about discrimination and violence, that prevents young people living with HIV from seeking health care or medical care. Therefore, we may say successful treatment outcomes in young people living with HIV may be enhanced or influenced through social support and stigma reduction interventions that are culturally appropriate and responsive to young people living with HIV in the Eastern Province of Zambia. Thank you very much.
Thank you so much, Graham. Very interesting work that you're doing. I will now turn it over to Steph.
Hi there. As we mentioned, my name is Stephanie, and I had the opportunity to work with Dr. Massa since 2019. Sorry about that. Try again. So we started working based on our mutual interest in HIV and Zambia. She helped me apply my previous work and mentored me as I've learned to merge my interests, and it's been really helpful. So again, thank you, Dr. Massa. So our paper was titled Walking and Perceived Lack of Safety, Correlates and Association with Health Outcomes for People Living with HIV in Rural Zambia. Just a second, for just look in the background here, I just want to note that this is obviously not rural Zambia. And that's just because I want to take a moment to appreciate that all of Africa is not what we see in the commercials with, you know, just terrible stereotypes that we have of, you know, third world countries or whatever term that we use these days. So obviously there are very beautiful and developed areas, but this particular paper is about rural Zambia. So if you can get the next slide, please. So first we'll talk about the background. And there will be multiple times that I will make references and parallels to the US just to be able to bring it home and make things a little bit more, to solidify concepts a little bit. I hope that's helpful. It's for a couple of reasons. For clinicians, educators, and researchers who haven't had the opportunity to live or travel abroad, it's really easy to other people and countries. So I want to show that there are common structures and macro level issues that really transcend places and cultures, and they create prevailing predictable patterns. The second reason is we can compare and contrast, provide opportunities to critically engage with information and help us question some of our own assumptions. So having said that, I'll just quickly share my own positionality. I present as a straight cisgender Mexican-American woman with no visible disabilities or religious affiliations. So without further ado, next slide, please. The background is that geographic inaccessibility to healthcare services contributes to poor health outcomes. And that's sort of a global issue that we see. And so when many of us in the US, again, this is contextual, but when we think of distance, we think of an ability to jump in our car or some other form of motorized transportation and get somewhere rather quickly and safely. But let's think of for a second a rainy day, and our primary mode of transportation is a bike. And we usually follow the law and we use the bike lane in like the middle of the road. And on a rainy day, well, on any day, it's probably not the safest, but we also don't have a money tree, and we don't have money to call an Uber. So a bus also won't get us to our appointment that we have on time. And so we also, basically what we see is that we don't have a suitable mode of transportation. We have limited financial resources, and we are we have limited travel time. So this is a common pattern that we see. Next slide, please. So when we are dealing with issues like this, we see that accessibility is associated with engagement, adherence, and retention. If we're dealing with these issues like upfront in our face every day, we may not want to be engaged with healthcare, whether or not we want to really even attend our appointments, whether we can attend our appointments on time, whether we can adhere to doctor's orders, and whether we can remain engaged in treatment for long term. And all of those things really do affect prognosis long term. Next slide. So in sub-Saharan Africa, people living with HIV have this problem in particular. And obviously, these have implications for their treatment and their care. Next slide, please. And so the next one. So the specific problem that we were looking at is that Zambians in rural areas are disproportionately affected by this geographic inaccessibility to healthcare. Sorry. Next slide. One of the reasons that we see that is for a couple of reasons. There are significant disadvantages, obviously, associated with both intentional and unintentional injuries. This is sort of a public health perspective. Unintentional injuries are associated with weather, unsuitable transportation, collisions, conditions of road, and difficulties related to illness. So these are, if we look at this road here, what we see is that cars and people are along there. It's a one-way road and people are walking and excuse me. They're along the same road, which makes it difficult in general to navigate. But then we also add we have a statistic that shows us how difficult it can be generally to even drive in Zambia, that it is one of the most, sorry, I lost my train of thought, lost the word. It's one of the most fatal issues in Zambia. And so when you add walking along those areas, dealing with collisions and being a person along those areas is very dangerous. When we add weather conditions during rainy season, we're dealing with roads that can be washed away, and it makes, again, it adds additional barriers. Conditions of roads can be sort of they're not like paved, and obviously those are easier to wash away. When we have a chronic illness that can impact our physical, our ability to walk long distances, when we're taking medication that can impact our abilities to walk, induce nausea, things like that. Obviously that impacts how long, how far, how safely we can walk. Then we add intentional injury that can, that's related to our HIV status in general, and gender-based violence. So again, globally, what we're looking at is people with HIV are have a higher risk of experiencing violence. So again, when we look at that risk and perceptions of safety, those are very real barriers. For women specifically, gender-based violence is a very real issue to deal with. Again, globally, even more of an issue when we're talking about long distances, which is a problem in Zambia because people who are walking from rural areas take significantly longer to walk and get to healthcare facilities. We're talking 70 minutes versus 47 minutes for people who come from urban areas. Next slide, please. Excuse me. So our methods, our constructs were fairly straightforward. Treatment outcomes, we had adherence to ART, barriers to pill taking, psychosocial outcomes were perceived stress, hope for future. And then we also had the perception of lack of safety was just one indicator. And the question was whether or not somebody had missed an appointment because they felt unsafe. So this was, it was a 5-question or a 5-point Likert scale. that ended up being dichotomized based on distribution. Next slide, please. So we had 101 people from 2 different hospitals. They were recruited from an ongoing intervention. Next slide. We ended up using OLS and excuse me, and logistic regression. We used MI using chained equations approach to reduce bias from missing data and to help increase power. Sorry, next slide. Our findings for that education, excuse me, education level, livestock ownership, distance, and travel time in place of residence were associated with perceived lack of safety. So lower education, higher livestock, higher distance and travel time, and further distance. Sorry, that was, yeah, it was further distance. Were associated with a perceived lack of safety. Next. And then based on for the treatment adherence and barriers to pill taking. Just write this next, I cannot remember. Excuse me. Both treatment adherence and barriers to pill taking were negatively associated with lack of safety. Discussion, please. I'm sorry, next slide. Sorry, I'm looking at 2 different things. Perceived lack of safety and psychosocial outcomes were negatively associated with, hold on, sorry. Participants who reported feeling unsafe compared to participants who felt unsafe. I'm so sorry. Participants who reported feeling unsafe when walking scored 2.76 points lower on agency subscale compared to patients who did not report feeling unsafe. That to me was an interesting point to point out. So participants who felt unsafe when walking reported lower levels of hope for future perceived safety. Seems to have a larger negative association with participants motivated to carry out their plans compared to perceived safety to carry out plans to achieve their desired goals. So these were 2 parts of the overall hope score. Discussion, please. Next slide, please. Sorry. So what this is telling us is that perceived lack of safety when traveling by foot appears to predominantly affect rural and low socioeconomic ART patients. This again was associated with what makes us believe this is the education, the owing money, being female. Those are sort of associated with the socioeconomic status, and that perceived lack of safety can be a critical but understudied factor affecting ART patients' psychosocial health. Next slide. And actually, I think we're going to be able to discuss this during our discussion. So I will wait. Thank you. Same. Sorry, the rest of it is going to be discussed later.
Excellent. Thank you everyone so much for joining and being a part of this presentation. Thank you, Steph, so much for your presentation. Very interesting work. I will allow folks to put their questions in the chat right now, and I'll have Dr. Mata open it up with some of the questions that we've prepared for our speakers.
Okay, thank you, Miranda. I just want to recognize some of the folks who have joined us. Matthias and our colleagues at Rising Fountain Development Program, they are responsible for why we have these data. So they are joining us from Chipata in Eastern Province, Zambia. I also want to for our oops, go ahead, Matthias.
Hi, Ren. How are you?
Good, good. Thank you for joining.
Thank you so much. Thank you.
And also Dr. Joy Noel Baumgartner, who recently joined our faculty, and she's also done a lot of work globally, especially in sub-Saharan Africa, with interest in health and yeah, maternal health, maternal and child health. So thank you both for joining in. Yeah. Okay, so let me ask this question to all of you. So how, given that some of the topics that you were talking about, the findings are well, they're from overseas, from Zambia particularly, how do you think those findings translate into your work, particularly those amongst you who are doing work here in the US?
I can go first. I think that it is, it's easy to translate this work into the work that I'm doing here in the United States, especially with regard to nutritional status affecting your self-efficacy. I think we may not see as much of the undernutrition here in America, but we see the opposite of that, and how overnutrition or obesity status will impact your self-efficacy or your belief to do something because of the various weight stigma that we have in the United States, which will then probably impact your academic outcomes if you don't feel like you can do things because of these possible internalized discrimination. It's more likely to affect these outcomes. So I think just in general, implementing more self-efficacy measures or just self-efficacy boosting things for vulnerable populations, especially young women and young men of color, will be really important when creating programs in the future.
I'll speak for me as someone who most of my work is done here in the United States. I am fortunate to work with Alex and Dr. Massa and explore Alex's research area with her related to nutrition. And working on this has really reminded me that, at least for Zambian youth, underweight is just a symptom of a much larger issue related to things like access, and what you have resources for. But in my work, self-efficacy is really important, and it reminds me that when self-efficacy can be better nourished when the family and the school environment and the neighborhood environment have their basic needs met. So it really kind of paints a picture to kind of the bigger level important factors that contribute to things like nutrition status on outcomes.
Graham?
I can go. Excuse me. For me, the implications, we have obviously research practice, and I actually also think there's some for education, but I think specifically for practice, what we see are opportunities for service delivery models that can help reduce some of the burden and barriers. So we can increase medication, like scripts, so that people don't have to encounter these these journeys that feel unsafe, that are too long, and they don't have to do it as often. We can have decentralized medication disbursement. So we've seen models where there are like community-based centers. We have home delivery, again, so that there isn't this onus on an individual person to go engage in these situations that are structurally, they're structurally created for people to feel like, essentially for people to lack autonomy. So the more power that we give people and the more opportunities for people to feel safe and to feel like they have their own health in their hands, the better. So there are lots of opportunities, there are lots of models, and the more opportunities that we have to implement interventions like that, the better.
Yeah, I thought this was also was an interesting experience for me, especially in the sense that my target population is women, not young people. And also that it's my first time actually doing a research focusing on young people in rural areas with regards to HIV. So for me, that was an interesting experience. And when I was looking at this paper itself from my research, I found that my area of interest, of course, it's prevention, HIV prevention, but I realized that there's an intersection, between HIV prevention and HIV treatment, So I thought maybe I should change my route, or I should add the aspect of treatment, to my area of interest, because they go hand in hand, So also I was also thinking I could at some point change my target population, as in young people, because it was so interesting to see that for the most part, most infections, they occur in young people, and Africa, or the sub-Saharan Africa, is mostly young population. So I thought it's interesting and important to focus on these young people who are mostly infected with HIV, particularly young women. So yeah, it was interesting. And I think speaking from the aspect of doing research in the US and Zambia, I haven't done research in Zambia for quite some time now. I would say maybe 5-6 years ago when I was in my undergrad. So most of my work has been focusing in the US. So this one was like, all right, yeah, it feels like home, So it was quite an interesting experience for me, and I look forward to more of these research. And I also wanted to add one more thing. I was thinking maybe in the future I could do a mixed study, just to understand different aspects of it. Because of course, if we're looking at the efficacy of social support groups, that is the quantitative aspect of research. But if I want to understand the actual reasons behind someone disclosing their HIV status, the best way is to have a discussion with them, sitting down with them and understanding their experiences, what really led them to disclose their status. I think that would be a good research study in the future, and I would definitely be happy to collect data, speaking with these young people. Of course, my Nyanja is kind of rusty, the one they speak in Eastern Province, but I'll try by any means, to do my job. But I think it would be a great piece of work if I was to include the qualitative aspect of it. Yeah, thanks.
Thank you. I think that's a good segue for a follow-up question, but I want to, if there are any other questions from, or if our colleagues have other questions about the presentations.
Well, I can say it's a really impressive group of students and all the work you're doing. So that was actually this is my first introduction to the doctoral work happening at the School of Social Work. And so now you've like set the super high bar for anyone else I meet amongst this group. But I do have a question about the nutrition aspect. So I do a lot of work in this area in Tanzania, and we work with schools and talk a lot about feeding programs and trying to measure nutritional status amongst adolescents. And I wanted to know your thoughts about the difference between undernutrition and household food insecurity and how that plays out with mental health and self-efficacy, because they're different. They're related but different. And I just didn't know if that was like another area you were just like putting to the side for a little bit, or because you've got a very complex model that you've already analyzed, but I just wanted to ask about that.
I love this question.
The answer to this question, go ahead.
Yeah, so my larger research interests are the intersection of food insecurity and mental health, which is different than weight status, right? We're seeing more often than not that those who are experiencing obesity are more likely to be food insecure than in America, at least. I can't speak much to the international context, but I do agree that those things are important. And you were asking about self-efficacy, food insecurity, and mental health.
Mm-hmm.
I'm not completely familiar with the literature on food insecurity, mental health, and self-efficacy, but I do know that food insecurity impacts mental health through many different pathways. And I also feel that it's a bidirectional relationship. Experiencing mental health may lead you to experience food insecurity. And by mental health, most of the time, it's anxiety and depression. And then also not having enough food to eat can lead to experiencing anxiety and depression related to where am I going to get my next meal. I'm not sure how self-efficacy could come into that model. And I'm using my statistical equation modeling brain. But I do think if you feel that you have some sense of self-efficacy in getting treatment for your mental health, if that's something that came first or that you feel like was a pre-diagnosis to food insecurity, that could impact and make you feel more empowered to seek out services such as food banks or asking for other ways to get food. I'm not sure how self-efficacy could possibly lead into, and I'm like doing a fake model in my head, I speak with my hands. I'm not sure how self-efficacy could lead into food insecurity, but I think that would be a great research area to look into for sure.
I can say it's a very up and coming and hot topic for adolescent mental health, especially in East Africa right now, because depending on whether the framing is for nutrition, which ends up turning it more individualistic versus household food insecurity, and then you end up with more structural interventions. It's almost like, I feel like at a policy practice level, like being really careful to couch the individual under or over nutrition, because then you end up doing adolescents, and again, this is my experience in Tanzania, they get referred for nutritional services with a specialist. It's like, okay, that could help some acute needs perhaps, but not the underlying issues. And so it's just really interesting, like how the policy conversations are happening, and people default to what they think is easiest to, at least policymakers sometimes. So anyway, I love your topic, love it.
Yeah.
So,
and I would love to touch base with you maybe later or further down the line just about what this looks like in Tanzania.
Yeah, it's a complicated issue. I would love to chat more.
Yeah, but I think one thing that we can, because I think part of what we've experienced is, like in some of our work, like in Ghana and South Africa, we have questions on household food insecurity, but we did not, or we haven't measured nutrition or nutrition status. So I think the Zambia data, particularly from the AGEP done by Pop Council, would give us, we will be able to test hopefully what is it nutrition or is it household food insecurity that's more predictive, right, of mental health status. But to say that in other countries where we've done work, like for example in Ghana, we know that household food insecurity or households' inadequate access to food is negatively associated with young people's mental health and also their future orientation, and a lot of, even their academic self-efficacy, yeah, it's just wide ranging, but yeah, thank you for that question.
Well, yeah, just a quick add-on, Alexandra, we could chat sometime, but even the measurement issues for adolescent nutrition are quite complex, like the BMI and the mid-upper arm circumference and all of that.
Yeah.
Like the measurement
BMI
stuff's
is-
really kind of cool because they're going through puberty. There's just a lot happening.
Yeah, and BMI is no offense to anyone that likes BMI, but it is a failed measurement tool that I really think we need to couch for all populations, but especially for children as they're growing and they're hitting these rates at such different points that age isn't a good predictor of that.
I just added a link about mid-upper arm circumference that we tried to do with adolescents in Tanzania. The guidelines are still evolving at WHO if you're interested in that, but it's a good measure that's community-based. Doesn't get it overweight though, gets it under. So. Sorry, I'll let someone else ask the question.
No, it's okay. So I guess I'll follow up on Graham's point. So what would you do differently if you get to do the study all over again? What would you do differently?
I think just thinking about Graham's point and the conversations that the three of us had while we were writing this paper, the point of BMI was a big conversation that we had. Like you mentioned, adolescents are growing and developing, and is this the best kind of way to look at this? I know gender attitudes was another one that we looked at, that the measurement of that was a little bit wonky. I mean, for starters, the questions came from multiple studies, and it leaves a little bit of space for exploring that some more within this population and measurement development and those sorts of things. But to Graham's point, there's secondary data is excellent in that it really helps us disseminate knowledge much quicker because of the repeated access to large samples. And there's this really important aspect of primary data collection, whether that's qualitatively or follow up quantitatively, that can say so much more than we could get with secondary data. So to do it differently, to piggyback on Graham, probably some qualitative analysis.
I think for us, one of the things we discussed were the measurement of perceived safety, which is obviously the crux of the paper, because it was a one item measurement. It's obviously limited, but we didn't really have any additional ways to measure that. I think we're also balancing participant fatigue. There's a lot to deal with there, especially when you're working with people living with HIV. There's fatigue in pretty much everything you do. So knowing that they're already participating in another study, knowing that they are dealing with walking to their appointments, that they're going to have to walk back after they see us, things like that. I think there's trying to figure out that balance. So I think that's one potential opportunity to delve into. I think probably for this specific topic.
And I think also building on what Dr. Baumgartner mentioned earlier about policy and practice within the context of what Steph presented. I mean, we're not advocating for large scale road infrastructure. I mean, that would be great, but that's beyond the scope of what we can do as social workers. But I think, as Steph mentioned earlier, it's more this differentiated delivery model, particularly taking the health clinics or some of the health facilities closer to the communities, not necessarily the entire health clinic, but dispensing, being able to receive medication through a community-based group, or just like what they are currently doing actually in other parts of sub-Saharan Africa. And I think Zambia has piloted differentiated care delivery for ART patients.
So in Zambia, if you miss a number of your appointments, and I only know this because I have worked in a couple of the ART clinics there, they do have like a checklist, and the social workers or the counselors will see like what are those potential barriers. But I don't ever remember seeing anybody looking at this issue of distance and safety before. So this could actually really be a missing gap on the assessment of a barrier to timely care. So even at a structural level to screen for potential barriers, you know, like this would be a great recommendation of something to include.
I agree.
I was, I don't know, is it time up?
You can add one last point, Graham, if you would like to.
Yeah, thank you. Yeah, so I remember I sat down with Dr. Massa a few weeks ago. We discussed about doing a research, you know, with regards to the LGBT community in Zambia. Because, you know, in Zambia, being gay is illegal, so to speak. You know, if you are found to be gay, you'll find yourself in prison for 14 years. Well, don't blame the Zambian government. Those are colonial laws. But anyway, I blame them as well because they're not taking them down. But we discussed about doing a similar research, you know, but focusing on the LGBTQ, understanding where they get their social support in terms of disclosing their HIV status. So I was thinking, you know, it may be different from individuals who are not, for individuals who are in that community in terms of the social support. That's just my hypothesis, you know, because we don't really understand what goes on in that community unless you are in that community. So plus the group itself is a small community in Zambia, but we don't know whether it's big because it's illegal to be in that community. So I was just thinking like we could do something like that, and we could use a snowballing kind of research, you know, the same way we could conduct a research on sex workers, because, you know, sex workers, it's illegal to be a sex worker in many places in this world, but research has been done, and the way it's been done, it's using snowball process and all that type of studies design. So yeah, I'm just thinking about that. The LGBT community isn't really my focus, but I was thinking maybe, you know, just to try to expand my horizons, you know, or to understand these other different groups that are being affected with HIV. Yeah, thank you.
That's a good point. And I think it's encouraging that there is some research coming out on LGBT communities from Zambia. So that shows that it can be done. And it's possible to get the necessary approvals, IRB approvals, otherwise to do that research.
Yes. Amazing work, everyone. Thank you so much. There will be a link to this recording on YouTube at some point. I can share it out with folks for them to disseminate across their networks. But thank you all so much. It was a pleasure having you all, and I look forward to more events like this.
Thank you.